Chaplain John Gerhardt.
Thank you, Dr. Malone. And may we bow our heads in prayer. Lord our God, we give you thanks this day for the stature, the influence, the scope, and the power of this great healthcare system we call Sarasota Memorial. Yet we pause as we begin this meeting of our hospital board because we are mindful that to whom much is given, much is expected. We humbly call upon you, the author and creator of life, to bless our efforts to enhance and preserve the lives of those who seek our care. We pray that you, the great physician, will guide our staff and this, our hospital board, as together we seek to use our vast resources to heal, to comfort, and to bless the needy amongst us. These things together we pray. Amen.
Let's join together in the Pledge of Allegiance. The Pledge of Allegiance to the flag of the United States of America, to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. I call the meeting to order of the Sarasota County Public Hospital Board. And let me just provide this. Any citizen desiring to address the hospital board should turn in a speaker card to the board secretary. If the citizen comment pertains to an item on the agenda today, the comment will be heard early in this meeting. Otherwise, it will be heard toward the end. Speakers are asked to limit their comments to 5 minutes. Vendors, suppliers, or other persons seeking hospital contracts awarded on a competitive basis are reminded that their ability to address the board may be restricted by the terms of the invitation for bid, request for proposal, or other purchasing criteria. Lastly, the board has established a claims adjustment review panel comprised of representatives of the board, the medical staff, administration, and legal counsel to review and negotiate the settlement of claims. Accordingly, the board will not entertain comments on or discuss or negotiate claims at this meeting. So, I'd like to have approval of the orders of the day, please. So moved. Any comments or questions? All those in favor, please signify by saying yes. Yes. Opposed? Thank you. The motion carries. And now approval of the minutes of the meeting of May 19th. So moved. Second. Any comments, questions? All those in favor, please indicate by saying yes. Yes. Opposed? Thank you. Motion carries. And we're looking forward now to a topic of spinal sonography and obstetric anesthesia by Dr. Salinas. And I think, Dr. Rebecca, you're going to do that. Excuse me, you're going to introduce him.
Yes, I am. Thank you, Dr. Malone. It is my pleasure to introduce this month's speaker, Dr. Raphael Salinas. Dr. Salinas attended the University of Florida for undergraduate education and medical school at the University of Puerto Rico School of Medicine. After completing a pediatric internship and anesthesia residency at Jackson Memorial Hospital, he remained in Miami for postgraduate training at Miami Children's Hospital. He joined Sarasota anesthesiologists in 1986, eventually focusing on obstetrical and regional anesthesia. Appropriately, he will be speaking on spinal sonography and obstetric anesthesia. Please welcome Dr. Salinas.
Thank you very much for your kind introduction. And I'd like to begin by saying that this is a topic that is very near and dear to my heart. I actually can't wait to come to work to do it. And it relates specifically to a new development that we have introduced about a couple of years ago into our practice that has been nothing short of miraculous. And I'll try to demonstrate why. It'll be a very quick whirlwind tour through a topic that I could probably spend 2 or 3 hours, but I won't bore you with that. Essentially, the practice of spinals and epidurals is central to what we do in our practice. It provides the most effective means of labor analgesia and spinal are very important for C-sections. And so anything that reduces the technical difficulty of the procedure will have a great impact on how safe we're able to perform the procedure and also on patient comfort. They have fewer side effects than generals, and essentially we avoid generals as much as we can, and we reserve general anesthesia in our practice only for patients with complicated deliveries and patients that have contraindications. In addition, under epidurals and spinals, the patients are awake and they're able to participate in the whole birthing process. And this slide just depicts the area that we enter with a needle without getting too technical. Essentially, we have to choose the soft tissue interspace between adjacent vertebra. And depending on where that needle ends, we could either provide labor analgesia for labor pain or actual spinal if we go in just a little further. This slide depicts the importance of knowing exactly the level that we enter the spine in order to avoid spinal cord injury. Now, ordinarily the way that this has been done, and it's still done in most cases and in most hospitals, is by what we call the palpation technique. And essentially, this clinician is feeling with his right hand the hip bone, and that pretty much gives us an approximation of the spinal level. And again, we want to enter the third or fourth lumbar interspace. The left hand is palpating the space between the spinous processes, the backbones, where we actually enter the needle. The problem is that even though this method has served us well for many, many years, and it has acceptable rates of success and complication, it has significant limitations, and we encounter those limitations every single day. For instance, in patients who are obese or have swelling or any form of spinal deformities of previous spinal surgeries, palpating the back isn't as easy, and it's really not that helpful. In addition, we're not able to take into account variations in anatomy, spinal deformities, or and the like with the palpation technique alone. And this is a case in point. This is actually a case taken from a study that showed how reliance on feeling the spine is problematic. If I may demonstrate here. This was the level that was determined just by feel alone, and this is the hip level determined by ultrasound. And this depicts the fact that ultrasound is much more accurate in determining a safe level of entry versus the palpation method. Using the palpation method would have sort of guided one towards entering the spine at an unsafe level, too close to the spinal cord. And again, feeling the back and determining the correct level of insertion of the needle in this patient proves very difficult. It's even hard to feel where the middle of the spine is. And this, with the obesity epidemic, we see this quite often. In addition, pregnancy is associated with some anatomic changes of the spine that make palpation even more difficult. The patient's sway back is accentuated, and it's hard for them to get in position to feel the spaces properly. In a patient like this, the palpation of the landmarks is totally useless and quite misleading. This is a patient with a deformity called scoliosis that involves a very complex lateral deviation of the vertebra as well as rotations, fiendishly difficult to palpate processes. Fortunately, things have changed. And the advantages of ultrasound are numerous. Essentially, it just allows us to see what's beyond the skin and image the spine. And then it allows us to make marks on the skin, which later guide the needle entry. This has proved absolutely practice-changing. And these are examples of images obtained with ultrasound. The image on the right is actually an ultrasound image that depicts the levels, and we're able to accurately identify them so that we could provide the anesthetic in a safe manner. This other image allows us to determine where the exact middle of the spine is, which is especially important for an effective epidural where we have to thread the catheter right in the middle. And finally, this image is actually quite new. This is the first time that we're able to image the actual target. It's the space between the vertebra, and this gives us an indication of the depth to our target, and so we're able to select and tailor the anesthetic to the individual patient. This is very new in our practice. This has never been possible before. And these are actual photos of the marks. The vertical line in the lower caption there is the midline, and the horizontal line depicts the correct spinal level, and where the two intersect, the crosshairs, is our actual needle insertion point. So we're going in knowing exactly where we're at. This is really important because it reduces the number of spinal attempts. And we know that with increasing number of unsuccessful spinal attempts, needle insertions, patient discomfort ensues, and also the risk for nerve injury increases. So this actually gives us a very good opportunity to enter the space, usually within one attempt. What follows is briefly an application of ultrasound in patients with very challenging anatomy, and in each of these cases, the ultrasound made the difference between a successful spinal epidural. And incidentally, I have encountered patients in my practice similar to these. This patient has uncorrected scoliosis. You could see the lateral deviation of the spine, and the images on the right actually depict the deformity. Through them, we're able to actually identify a target for a needle insertion. This is actually ultrasound 201. This is actually kind of difficult, but once you gain experience with normal anatomy, then all this becomes much more useful. The next patient presented for a cesarean delivery after having a corrected deformity called scoliosis, where the entire spine was fused. And with the use of ultrasound, which yielded these interesting images, we were able to select the correct needle insertion point, and the patient was able to have a successful spinal delivery. So, and in this patient with a previous spinal surgery, there is an absence of palpable landmarks. The spinous processes are simply absent. Nevertheless, the patient was able to have a spinal anesthetic, thanks to the images from the ultrasound, which appear on the right, and we were able to detect our target through the scar tissue in the back. So in sum, ultrasound has been nothing short of miraculous in our practice. I use it every single day, and I have to say, in all fairness, the technology continues to prove itself. And that concludes my speech. Thank you very much. I appreciate it. And a very special thanks I'd like to extend to Alex Quarles and the Sarasota Memorial Healthcare Foundation for their generous support of the program. And through them, we were able to obtain our own ultrasound scanner dedicated to our use, which we use all the time. Thank you very much.
Well, thank you very much. Are there any questions for Dr. Salinas? No, we appreciate it very much, and we'll pass the word on to Alex Quarles. Thank you. And we'll move on to the report of the medical staff. Dr. Cindy Von Maldner, Chief of Staff.
Thank you, Madam Chairman. I have one agenda item for the board, and that is approval of privileging guidelines for bronchial thermoplasty procedure. These guidelines have been reviewed and approved by the Medical Executive Committee, which recommends your approval.
I move approval of the privileging guidelines for bronchial thermoplasty as recommended by the Medical Executive Committee.
We have a second, and any discussion or questions? Hearing none, all those in favor of the motion, please indicate by saying yes.
Yes.
Opposed? Thank you. Motion carries.
That concludes my report.
Thank you, Dr. Von Maldner. And now the auxiliary report, Mr. Robert Dutrell.
Thank you very much.
President.
There are 125 teenage volunteers working here for the summer months. There were 2 orientations to prepare them for the service in the hospital. These young folks fill a large gap in the volunteer force, covering for the snowbirds, volunteers, and others that are on vacation. The teens work in discharge, courtyard tower desk, gift shop, and the clinical research area. 3 of these specially trained teens work in the perioperative transport. Another special 3 work in the cardiac section of the hospital. We are very proud of these teen-age volunteers. We expect the electronic funding group to have an electronic sale on July 15th and 16th in room 4A and B. The show will feature video cameras, TV, DVD players, memory cards, GPS navigation systems, laptop, computers, television receivers, and many more, and I hope you all can visit the sale. Concludes my report.
Thank you very much. And we'll move on to the Secretary's report, Mr. Thomas Towler, because Alex Quarles is not here today.
Thank you, Madam Chair. I have the July board meetings in front of me that we will meet on July 1st, Tuesday, at 7:30 for the Quality Committee, 8:30 the Finance Committee, 9:30 the HR Committee, 10:30 the Audit Committee, and on the 21st, which is a Monday, we will have the public board meeting at 1 o'clock. That's my report, Madam Chair.
Thank you very much. The Treasurer's report, Mr. Joseph DiVirgilio.
I have one item today, and that is the approval of the bad debt and charity care. In that regard, I move approval of the bad debt and charity care for the month ending May 31st, 2014, in the amount of $10,425,000.
Second.
Any discussion? Hearing none, all those in favor of the motion, please indicate by saying yes.
Yes.
Opposed? Thank you, motion carries. Thank you. So on to the operations report, Mr. Nelson Lane, Controller.
For the month of May, the operating revenues for the system were $49,986,000, which compares favorably to both the forecast and the prior year numbers, which were $44.3 and $44.6 million respectively. For the year-to-date period, which was an 8-month period, our operating revenues were $380,406,000, which is, again, favorable compared to both the forecast and the prior year. Total expenses for the month of May were $48,524,000. That compares to a forecast of $44,800,000, and prior year total expense of $44,194,000. And for the year-to-date period, the 8 months, our total expenses were $373,906,000. And that brings us the operating income, which for the month was $3.8 million, which was favorable compared to both the forecast and the prior year. And for the year-to-date period, $25,694,000, which again is favorable compared to both the forecast and the prior year, and gives us an operating margin for the 8-month period of 6.3%. We had 131 hours per adjusted admission in the month of May, compares to last year of 130, and for the year-to-date period, we are running at 126 hours per adjusted admission. Looking at a few other statistics, our average daily occupancy in the hospital, including observation patients, was 406 in the month of, for the year-to-date period average, and that compares to a forecast of 389 and prior year amount of 388. We had 19,340 admissions for that 8-month period, which is significantly higher than both the forecast and the prior year. And our average length of stay for this 8-month period was 4.6 days, which is slightly lower than the same period in the prior year. There were a total of 13,145 surgery cases in May, in the 8-month period that ended May. And that is similar, slightly under the forecast amount of 13,544 and the prior year amount of 13,220 surgery cases. And we had 1,980 births for that 8-month period. There were a total of 274,934 outpatient registrations. That compares to the forecast of 285,762, and prior year for the same 8-month period was 268,110. We had 73,567 emergency care center registrations. That includes both emergency care centers here at the main hospital and also in Northport. And that number is in total higher than both last year and the forecasted amount. And our case mix index is running higher in both for all patients and for Medicare patients for the so far for the 8-month period at 1.66 and 1.8 respectively. My report.
Thank you very much. And so Ms. Jan Mock, Chief Nursing Officer.
Good afternoon. Under people, I'd like to report that this week, actually next week, we will be getting a new Director of Perioperative Services. Her name is Karen Benedict, and I will introduce you to her after she arrives. But she comes to us from Pennsylvania, and she worked at St. Mary's Medical Center in Pennsylvania. And she's done a lot of work in all the areas that we're interested in on improving core measures, patient satisfaction, improved utilization, and also flow, and also increased volumes. So she went through as we always do, a peer interview process. We're very much excited about having her here and look forward to working with her. I do want to take this opportunity to thank David Patterson, who has been filling in the interim role and has done a wonderful job. So if you see him, please let him know that he really has filled in there and done a great job. I think all of you are aware that the Gallup Survey, which we just took, is complete now, and we had 94%, or 3,595 of our employees who registered their survey of the engagement of our employees. And this means that we're very interested in their opinion counts, and we're looking forward to the results that we can start working on those. And in the end of June, we will be getting those results, and each department and overall as an organization will be working on the results and developing action plans on the basis of that feedback, and you'll be seeing those results. Under service, I'd like to congratulate the outpatient team. They hit 86%. David will go over that in detail, of a goal of 83. And under Hcaps, we weren't as happy with those results as the outpatient, but we missed 3 domains by 2 points, and so we're almost there. We just have to continue to work on that. And we had all-time high scores in nursing communication, which was at 81%, and we tied the best scores on willingness to recommend. So continued work on Hcaps and all the caps that we'll be working on. Under quality, I'd just like to mention, as David, I think, will mention about the Nursing and Rehab Center, who went through their ACA survey, and he'll go over the results. But on Friday, we had a celebration I attended at the Nursing and Rehab Center for recognizing the staff for the great work, and they are very, very proud. So we're very proud of them. June 19th, there will be a public selection of rounds for the rehab facility for consultants. And then there's a city notice that went out and an application for the neighborhood workshop for this project, and for July 16th in the Waldameer Medical Plaza. We remain on the main campus. We're working on the final moves, and they're on task and on time frame. And remaining staff for the main plaza have signed off on all their plans, and they will be out of the main plaza facility by the end of the calendar year. So a lot of movement is going on there. Under finance, we're working on our 2015 capital budget, which we should be done shortly. And we are now working on our operational budget, which we will hopefully be completed by July 7th. And that ends my report unless anyone has any questions.
Thank you very much.
Thank you.
There are no board reports today, so we'll move on to committee reports. And just a brief update on the CEO search committee. We're completing all the qualifications and scope of work and job description, and completing all the rest of the process and timelines that we'll undertake. And so more on that next time. So we'll move on to the Governance Effectiveness Committee. Ms. Alex Miller.
Thank you, Madam Chair. The Governance Effective Committee met on June 5th. The committee discussed the following agenda item: appointment and reappointment of community members. The committee has reviewed current community members and the resumes of a number of people interested in serving as community members. Dr. Ballone, Gwen, David, and myself conducted interviews with prospective members. The committee is in the process of finalizing the selection of appointees, and their 2-year terms would begin November 1st. And that concludes my report.
Thank you very much. So we'll move to Mission and Planning. Mr. Gregory Carter.
Thank you, Madam Chair. The Mission and Planning Committee also met on June 5th, and we started with Deb Bohannon, Director of Radiology, who presented a request for replacement of the CT scanner on the main campus. There are limitations with the current CT suite, and this is the oldest unit produced, or purchased actually, in 2001. The end of life for that unit was in January 2014, and it is no longer being produced, and parts are no longer available. We are unable to do cardiac CTs on this campus, and processing speeds are longer than the newer scanner. The older unit does not have the radiation protection devices as the newer units. We have 2 cardiac thoracic radiologists on staff, and one, Dr. Krishna Nalameshetty, sorry, reviewed the image quality and clarity variations in various scans, and Deb also reviewed the project costs. And at this time, I move approval of the computer tomography scanner replacement project at a cost not to exceed $838,000 as recommended by the Mission Planning Committee.
We have a motion and a second. Any comments or discussion? Hearing none, all those in favor, please indicate by saying yes.
Yes.
Opposed? Thank you. The motion carries.
Next was the Rehab Facility Selection Committee, and Tom Perigo discussed the selection committee meetings held on May 29th to review and select the architects, engineers, and general contractors for the rehab facility. And at this time, I move approval of the ranking of the general contractors for that proposed rehab facility in alphabetical order. They are CPPI Willis Smith Construction, DeAngelis Diamond Healthcare Group, and Skanska.
We have a motion and a second. Any discussion? All those in favor of the motion, please indicate by saying yes.
Yes.
Opposed? Thank you. Motion carries.
Okay, next is the architects and engineers, and I move approval of the ranking of the architect engineering firms for the proposed rehab facility in alphabetical order also. Flad Architects, Gresham Smith and Partners, and HRD Incorporated.
We have a motion and a second. Any comments or questions? All those in favor, please indicate by saying yes.
Yes.
Opposed? Thank you. Motion carries.
And finally, the next item was the Nursing and Rehab Center update, and Maria DiCarlo The Executive Director of Rehab introduced Candy Wetherell, Administrator of the Nursing Rehab Center. And as Jan mentioned, they had their ACA survey the last week, and there was not one deficiency found. She presented an overview of the NRC, and it is a 12-bed facility with 2 units, short-stay rehab and residential patients. They've been able to maintain a 4 to 5-star rating, and the NRC has 24-hour, 7-day-a-week skilled nursing care. She reviewed the facility's medical expertise, quality metrics, new partnerships, financial sustainability, payer mix, recent progress, and action items. And that concludes my report.
Thank you very much. Move on now to the Quality Committee. Mr. Robert Strasser.
Thank you, Madam Chair. Since Quality Committee meetings are held in closed session, I have nothing to report at this time.
Thank you. So on to the President's report. Mr. David Verinder, Interim President and CEO, welcome you to these proceedings.
Thank you, Madam Chair. I'm going to start off today going through our 2014 year-to-date report card through May. We start off in our Hcap score, which we have a goal of hitting 9 of the indicators at a 50% or better. As Jan reported a little bit earlier, we came in at 5, so a little bit of work to do into that area. We look at our outpatient Gallup scores. Our goal is at 83rd percentile. We're right now at the 81st percentile, so again, a little bit short, but pretty close to our goal there. In the people pillar, we had our Gallup, as Jan also mentioned, our Gallup employee survey. We have a goal of hitting a 4.26 grand mean score. That survey has been done, and we're compiling the results now, and I'm sure by next month we'll have a result to share with the board and the public. Merits on time at 95%, and we are exceeding that goal as of this date at 97%. In the quality pillar, our value-based purchasing at 100% or greater of CMS reimbursement. I will tell you we're just falling a tad bit short at 99.8%. Hopefully can close up some of that gap before the end of the year. Organization percentile of patient safety readiness at 95% goal, and I'm happy to report we are at 100% of that right now. Infection prevention, which is a combined overall standardization infection rate, our goal is less than a 1.0. We are a little bit higher than that right now of 1.12, but have a number of action plans going on with our medical staff and nursing and other clinical folks to get that number a good bit below the goal. Finance pillar, as Nelson reported earlier, our goal was 4.2%, and we're hitting a 5.2%, so we are exceeding that by quite a bit right now. And in growth, our strategic growth on inpatient admissions, our goal was 25,192. We're hitting a little bit over 27,000, so a very busy year so far. In our outpatient registrations, the goal of 812,000, and we're just a little bit short of that right now at 807,167. Looking a little bit more into service in our Hcap scores, as Jan reported earlier, we hit, from October to May, we hit 5 out of the 10 indicators at the 50th percentile. So we do have a little bit of work to do, and we have a good bit of a lot of teams around the organization concentrated on this. But what you will see is that 3 of those indicators are within 1 point of hitting that 50th percentile. So it's not like we're that far off. And if we just do a little bit better on those 3, we'll be at 8. And looking forward to that. And I'm sure we all are. We always like to compare our Hcap scores and see what they look like online on Medicare.gov, because that is the publicly reported information. At this point, at this snapshot, we do cover 6 at or above the national average, and we like to compare and see how we do compared to other high-end academic medical centers. So you see the Mass Generals on here, the Duke Regionals, the New York Presbyterians, Mayos. And I think when you look across the board, certainly some are doing better than us, but certainly we're doing better than others, but we certainly fall into the a mean number on that. We also like to look at how we're doing in regional competitors. And so once again, we start with our 6, and you look across at our regional providers in this area, and you see quite a few 0s and 1s and that type of thing. So I think we are doing pretty well when we look at ourselves compared to others. Looking at our likelihood of recommending, for the month of May 2014, really had a great month. Our actual number came in at the 86th percentile versus our goal of 83. And it's very nice to see a lot of the, some of the departments that have been struggling a little bit get to the middle and to the right-hand column. So very happy with those folks. When we look at our year-to-date number, as I reported a minute ago, we're at the 81st percentile, and so just trying to keep going with the momentum we've had for the last month and build off of that. In our people pillar, you may notice our controller, Nelson Lane, in a little different uniform than he is today. But it's our SMH bike team is once again riding in the Sharky's 12th annual Ride the Beaches, benefiting Live Strong. So thank you, Nelson, and for leading everybody in that. He really didn't want that picture, I'm sure. We also had another cause of celebration. Sarasota psychiatrist Dr. Parr Reed was honored with the Distinguished Life Fellow status, the highest honor for a psychiatric profession bestows. He was presented this award at the American Psychiatric Association's annual meeting in New York. Dr. Reed is obviously a tremendous asset to the community, our patients in SMH, and as I'm sure everyone remembers, he had served as Chief Medical Officer for the hospital. So please congratulate him when you see him. In other people, we had our own Dr. Jack Rodman, who is the Chief Medical Administrative Officer for FPG, was invited to speak with on Heidi Godman's radio show recently, kind of in recognition of Father's Day, to talk about men's health and the importance of screenings and exams and staying healthy longer. So please, if you didn't hear Jack, I'm sure there's a replay of it, and if you didn't, just tell him you did anyway, and he did a great job. Because he did. Jan also talked about our nursing memorial, our Sarasota Memorial Nursing and Rehab Center out on Clark Road in Rand. We had its annual ACA survey, which was May 27th. Pretty intensive 4-day survey. I know our leaders out there start losing sleep and things, but we all had confidence in them, and at the end of the survey, they ended up with 0 deficiencies. So it was a very, very well done. So please thank Maria and Candy if you see them, and really the entire staff out there. Something really to be proud of. Sarasota Memorial also won the Hospital Partnership Award from the Florida Association of Blood Banks. The Suncoast Blood Bank submitted SMH's nomination for the implementation of our appropriate inventory management, or our AIM. AIM is the data management tool for blood product inventory and blood utilization analysis. Helps hospitals and blood banks work more efficiently together for the benefit of patients. The award was presented at the annual banquet on Thursday, June 5th at the Hyatt Regency, and we'd just like to thank Charlene Harris and her team for putting that together along with our pathologist. In the area of growth, we had, this is obviously a picture of our urgent care center in Venice. And I would like to report that the city of Venice has approved the new signs for our Venice campus after quite a bit of work from everybody, and I know the board weighed in on that, which will allow us to have an additional building sign, monument sign, and directory sign at the building and at the main entrance. So very much appreciative of those efforts. In addition to that, you still see a picture of that same center here. And we were recently awarded the Beautification Award for the month of May by the Venice Area Chamber of Commerce. And we're very proud of that facility, and I'm just glad that it got recognized by the Chamber of Commerce down there to go along with that. And then finally, as Mr. Carter reported earlier, this is just an artist rendering, which if anything's for sure in life, it will change. But the artist rendering of the new rehab facility that is being worked on right now, this coming Thursday, June 19th, we'll listen to the final RFQs for final selection, and we'll go on from there and bring it back to the board for final discussion and approval. And that's my report.
Thank you very much. Any questions or comments? Thank you. We have nothing on the consent agenda and no public comments. So to legal matters, Ms. Carol Ann Kalish.
Just a couple of brief items. First, you'll recall at a prior meeting that we talked about the video and audio tapes and got the consensus of the board that there was no need to archive them with the intensity that you had been. And so attached to the original of the report of this meeting is a list of the audio and video recordings that are unofficial records of the board that will be destroyed. And you'll see that the most recent of those is dated in December of '06. So they are both old and taking up a lot of space and not an official record, so those will be destroyed. Also briefly, just following up on discussions that y'all have had in the CEO search context, and consistent with the board's constant evaluation of the relationship with Baycare, the management services component of that relationship will end on June 20th. And that concludes my report.
Thank you very much. Is there any other business for this body? Seeing none, we're adjourned.